Appreciate it. It's nice to be here. Glad to have everybody on. And again, I'm Michael Marchant. I'm the director for interoperability at UC Davis Health in Sacramento. And really what I want to talk to you about is kind of healthcare interoperability, the challenges, and really some of the, I'll call it buzzword bingo that you might hear around healthcare technology and some of the things that we're dealing with when we talk about information exchange in healthcare. A little bit about our organization. I'm at UC Davis Health in Sacramento. Again, we've got a large population of physicians, clinicians. We are an education institution, so we're training new physicians and dealing with that, as well as deploying technology and being a community resource as a level 1 trauma center. A little bit about me. Again, I'm not going to go into a ton of this, but I am pretty active in the industry. I'm on the HIMSS Interoperability and HIE Committee, Blockchain Task Force. I'm on the Diversity and Inclusion Work Group at the AAMC, which is the Academic Medical Colleges Group for Information Resources. And I've been involved in a lot of different industry things throughout a number of years in my 25 plus years in healthcare. Today's information, what I really want to share is really just kind of how things are converging in the healthcare interoperability landscape. We've got things like the 21st Century Cures, TEFCA regulation that is essentially forcing technology providers, health information networks, providers to share and provide information in a particular way, leveraging the FHIR, the FHIR, Fast Healthcare Interoperability Resource APIs, and really doing those things with particular use cases in mind and really expanding those over time. Looking at blockchain technology, if you're familiar with Web3, that's really foundational to the Web3 pieces. So really there's a lot of different moving parts in the healthcare interoperability landscape. And we'll just kind of walk you through some of those things, some of the history, some of the standards organizations that are defining a lot of these interoperability standards and how data is exchanged, and really just talking in general about technology. And really at the end, I'll kind of walk through where I see that blend, that perfect blend of leveraging existing technologies and future technologies or future looking technologies like blockchain to provide a longitudinal health record and a way to identify and exchange information. So the first thing is just what a definition is. What is health information exchange? Really, for us in the healthcare space, it's basically getting the information from one system to another for a particular use case. So the historical version 2 of HL7 interoperability is a trigger-based transaction that sends information maybe for an order for a lab or your pharmacy to send that information so that you can get a refill. And essentially what it does is it gives not only different systems within your healthcare organization, but also or other organizations outside information about what happens within the patient's encounters at your organization, including, as we all know over the last few years, a very heavy bent on public health, the COVID immunizations, the vaccination process, availability of the vaccines, how to get yourself scheduled for a visit, what information. So that was a real heavy interoperability requirement on the healthcare providers as well as the public health infrastructure, and really making sure that the right information was provided to the right folks at the right time. The interesting thing about health information exchange in the industry is that it can be a noun or a verb. Health information exchange as a noun is essentially a vendor or an organization that's providing that service for providers or for other organizations. So a pure example of that is SureScripts. SureScripts is a third-party entity that actually offers the ability to transmit your prescriptions between your EHR and the CVS or Walgreens or another pharmacy. So it's an organization that does that. It does the information exchange. There are other ones like health information exchanges in California. There's one in San Diego that was done for the Beacon Grant. There's Manifest Medics. There's a number of other organizations throughout the country that actually provide the health information as a service, mostly to organizations that might be limited in their technical competence in delivering that, or just needing some extra support and making sure that the right information, again, is getting to the right spot. And then the verb is really actually doing the exchange. So the physical taking of a transaction from one system and sending it to another. So the act of sending that information. Most of today's interoperability is governed by HIPAA regulations. HIPAA kind of talks about TPO or treatment, payment, and operations, is that you can exchange information with those particular use cases in mind between organizations so that you can get that care or get payment for that care, or provide treatment for those patients that are being seen in your organization or others. So just a little bit of history, legacy interoperability. Again, what are we talking about here? There have been historically a lot of different ways to get data from point A to point B. So point to point has been something that's been going on for a long time. You take information from one system and you send it directly to another. For a large system that has lots of different integrations, it's very difficult to maintain and support those. If system 4 on the image on the left gets upgraded, then I've got multiple different integrations that I've got to make some changes to, and make sure that all those connections are managed. I've got to document all those things. Just again, standard SDLC and support in operational mode. You need to make sure you have all of those things together and are supporting those to the correct way. If you look at the right, hub and spoke, again, there are some other examples in other industries where hub and spoke works very well. But again, you've got one connection now to the systems. You've got the hub managing all those things. So now if system 4 gets upgraded, you're really just dealing with that one connection between the hub and system 4 and making sure all that data exchange happens correctly between those systems. And the support model for that is you're putting more support and operational impact with the hub and staffing and supporting that, as opposed to trying to track down all the different integrations in the first version of that with all the point-to-point connections. As we look at out in the world, you can see other examples of where hub and spoke works really well. You've obviously got the airlines, you've got Amtrak. I think we all have ordered an Amazon package, and there's a warehouse somewhere in your neighborhood where if you wanted to go pick up your package, as opposed to having it dropped on your porch and worry about the porch pirates coming and taking that package that you ordered away, you can leverage some of their hubs. Or again, it just kind of gives you a sense of, you can centralize support, you can centralize operations. Hub and spoke really kind of gives the ability for the organization to muster their resources and provide standardized services while supporting still a large system of connections, and the ability to kind of deliver those sources all over the country, as you can see with the transport example that I have. So the main standards body in healthcare interoperability is Health Level 7 or HL7. They've been doing this for 35, 40 years. I probably have a version 2 of the HL7 interface that I wrote back in the 90s. It's probably still running. It's a very viable and even in use today, widely in use today standard. And really, they've got a number of different, essentially they're a standards organization that defines standards and for health data exchange for different reasons, and really trying to improve that across time. So version 2, I think says 1987. So that gives you a sense of when the organization was formed. And again, the different versions are different use cases. Version 2 is more of a trigger-based transaction. So a workflow happens in a system. Once that workflow is completed, it generates a transaction, and depending on that transaction, that information goes from system A to system B. Version 3 was a use case example where they were working to move from the text-based ASCII, and I'll show you some examples of that in a second, to a more XML web-friendly version of the interoperability standard. You've got your CCDs, which are more of a document-based exchange. So as opposed to specific information about a workflow, you've actually got the complete document, and it's kind of a more full wrapper of information that get exchanged. And HL7 essentially is was the birthplace of the FHIR APIs. So FHIR, again, is Fast Healthcare Interoperability Resources. It really, again, moves away from the historic or legacy interoperability to more of a web-friendly standards, leveraging APIs and defining those APIs for that exchange between systems. So again, just going to run through some quick examples so you can get a sense of what I'm talking about. Again, this is a version 2 standard. The HL7 organization went through and said, for different types of transactions, we're going to have different types, message types, and triggers. So ADT is a patient demographics, admits, discharge, transfers. And as you can see at the bottom, it has the patient information, it has the visit information, insurance information. So really demographic information about the patient. You've got orders, you've got results. Again, there's plenty of standards and details around that. And if you're interested, you can go to hl7.org. There's lots of documentation around the standards, but that's, again, some of the legacy ways that data is being exchanged on a push method. So I do something in my workflow and I generate a transaction and I send that out. And in my example, I would send that out to the hub, and then the hub could get one outbound feed from the demographic system and send it to as many different systems that they want that want that data. An example here at UC Davis, I think I've got 72 receiving systems for our ADT feed out of our EHR. Version 3 again was a move to XML, so trying to again move to a more at the time a more technology forward-looking example. Again, a lot of different use cases and ways that standard was deployed. Actually, a lot of the FHIR scripts or the pharmacy integration was done with the XML and the version 3 interoperability. And again, to give you a sense of what that transaction might look like for those of you technical folks that are interested in that sort of thing, really it just gives you a sense of what that version 3 transaction might look like with all your XML tagging and the things you would anticipate out of that transaction set. When we look at CCDs, so continuity of care documents, this is again a move forward. So a lot of the transactions were based on a particular event in a system, or you were doing an order, or you were getting a result. Moving to the CCD was part of the EHR incentive program. Some of the requirements of the EHR incentive program, if you remember that back in around 2010, was to provide documentation or provide interoperability standards for certified EHR platforms and allow that document to be exchanged as opposed to an individual piece of information like an order or a result or patient demographic. So now you can have a document that includes maybe a clinical summary, discharge notes, an H&P. You can actually package that all up, and this standard actually allowed for you to define those fields and the data that was sent in that information, sent in that exchange, so that they can be consumed by the receiving system. And again, part of the EHR incentive program required the ability to send and receive and consume the CCD documents. And again, just kind of for those, again, more technical or interested in the message level, our layer on this is kind of gives you a sense of what that transaction would look like. So on the behind or on the left, you'll see kind of the EHR screen, and on the right, you'll see what that information coming from a third-party system might look like in the transaction that gets sent through that CCD. The other interesting thing about healthcare is that there's lots of different standards. So not only do we have clinical exchange standards from HL7, but now we've got EDI standards. And again, some of those are written into legislation around claims administration. So X12 is the organization that actually had created and defined those ANSI standards for exchanging information like claims, claim status, payment, enrollment, things of that nature. Again, it gives you a sense of some of the transaction sets. Eligibility. So if you go into if you go into a provider's office and they're trying to determine whether or not you have insurance and what coverage you have and what information or what is covered by your insurance, again, you can see some of the transactions that have been defined through the X12 standards. X12 is again a different standards organization than HL7, but they're defining those standards, and it's a little bit of a different take on it's ASCII text, but it's got a different encoding schema and different segment separators. But again, it's human readable text. If you understood or were familiar with the standard, you could come in, pull a transaction up and read through and find patient demographic information, address information, as you can see on the transaction here. The last one that I'll go through is the IHE profiles before I get to FHIR. IHE profiles, again, is a query-based exchange that was developed in the late 90s. Essentially what they were looking to do was exchange information from a request and response. So I was looking for information on a particular patient. Again, it was started with radiology, but has been exploded to a lot of the national networks now use the IHE profiles to do that exchange. And it's actually some of the information that'll be exchanged through the TEFCA QHIN organizations that get formed through the TEFCA regulations. So again, just for those interested in what a transaction would look like. Again, with the IHE profiles, you'll see that information is getting sent out, a request for information from one organization to another, looking for, again, a lab report or information about a particular visit. And then that organization, the first question is do you have patient XYZ? And if the answer is yes, then it provides a list of the documents that might be available for them to exchange. And that's a standards organization or standard that's implemented very widely in healthcare today. And again, a number of organizations are transacting millions and millions of documents a day in this type of exchange platform. And that's where we get to the national networks. eHealth Exchange, Care Quality, Commonwealth. There's a lot of different alternatives to getting data across the country between your technology platforms. eHealth Exchange is more of a based on some of the government exchange. So DoD, Social Security, and the VA are connected through the eHealth Exchange, and that's how we exchange information with them today. Care Quality is a large national exchange standard doing essentially the ability to connect all the organizations, provide the connectivity, security, the access to the network, and facilitating that exchange. That's actually an organization that I'm on the advisory board for, and really what they're doing is trying to enable that exchange, as many use cases as possible that cover the treatment, payment, and operations that I talked about earlier. And again, the CCD exchange that they have or the IHE profiles that are being exchanged, somewhere north of 300 million documents a month are being exchanged in that network nationwide. Commonwealth is another a different model, more of a centralized model for exchange, but they also have a nationwide footprint, and again are doing that exchange very similar to Care Quality. Actually, what's interesting with Commonwealth is not only do they have their own network and exchange protocols, but they also are a Care Quality implementer. So if you're on the Commonwealth network, you can actually exchange information across networks. Same thing with eHealth Exchange. They've adopted the Care Quality standards and if you're an eHealth Exchange or a Commonwealth on those networks, you can actually exchange information with a Care Quality organization. The way I look at it is like, you had Beta and you had VHS, both were great standards for watching your videos back in the 90s. Care Quality VHS ended up being kind of the de facto standard because it was, for whatever reason, became the standard because of its quality, because of the way that it was implemented, and its adoption rate throughout the country. So,
hey, Michael.
Yeah, go ahead.
Gabriel asks, are there any insights if HL7 version 3 is being leveraged in Canada?
I believe so. I think that the version 3 standard is SureScripts, and I think SureScripts is an international organization that does prescription refills. There's also other pieces of version 3 that were widely adopted in Europe. Again, it moved away from the transaction-based interoperability to the use case. So it's more in the line of the document exchange, but wasn't widely adopted in the US.
Okay. And Steve asks, how is HL7 being accepted today?
HL7 is widely accepted. It's the international standards body. Actually, if you go to the hl7.org website, not only is it widely entrenched in the US interoperability landscape in setting the standards and defining new standards like the FHIR API interoperability that we're talking about today, but also in Europe and throughout the world, there's an HL7 International that tends to have meetings. Unfortunately, my organization is not sending me to Sweden for the HL7 International Conference, but it's a widely adopted standards body for healthcare interoperability throughout the world. And you'll see a lot of the same vendors. There are obviously a different population of vendors, but some of the same US vendors. If you're familiar with the HR vendor population, there's Epic and there's Cerner. There's a number of different vendors. Not only do they have a presence here or a widespread presence in the US, but they're also adopted in other countries. And those exchange standards, even though there's different rules like GDPR and some other things that will need to be in compliance internationally, the standards are still impacted, and they do help facilitate that exchange.
Is this only for Medicare patients?
No, this is for all patients. This is not specific to a particular plan, if you're a cash pay patient or you have no insurance, these standards apply to these standards apply to any interoperability for you. So if your patient goes to one organization, and again, let's just use the COVID use case. You come to UC Davis and you get your COVID vaccination. We actually will send that vaccination information to the public health office to let them know that vaccination has been administered. Part of that is that, again, over time, depending on your politics or aside, is if you have to have a health card, if you're going to a conference and you have to show your COVID vaccination, so that information from public health and from the EHR can actually populate a card that you can have in your wallet on your phone. So again, those standards are all defined through that interoperability and apply to everyone in that exchange.
Yeah, and Jennifer asks a really good question. How do you balance the interoperability needs and the protection for HIPAA today? It seems like the more connected you are, the larger the danger zone becomes.
Yeah, I think that so again, everything that every organization we exchange with is a HIPAA covered entity, and are exchanging information for that treatment, payment, and operations use case. There's a lot of I'll call it procedural and operational background into onboarding folks onto the network. So all three of the organizations that I'm talking about, eHealth Exchange, Care Quality, and Commonwealth, have an onboarding process, have a governance process. Essentially, there are some legal agreements that get signed to participate in the network. So from that standpoint, the exchange that you're doing on the national networks has a large governance process, and again, a lot of legal backing and organizations and agreements that get signed to participate in the network. I think from a patient protection standpoint, is that the exchange that we're moving into, and again, that's probably a little more nebulous, is that patient-directed exchange is when, and I'll get to example shortly, is when a patient wants to send their information to their phone. Once it's on their phone, it's outside the walls of the coverage of HIPAA. So any patient-directed exchange isn't bound by HIPAA, because the patient is directing you to share that information with that organization, whether it's with some app on your phone, or whether it's with another physician, or whether it's with a legal practice, or for whatever reason you want to exchange it with your aunt and you want to give them access to your information. Anything that happens outside of a healthcare operational exchange, which is what we're talking about with HIPAA covered entities and business associate agreements, that are the legal and contractual language that gets put into place to protect that information. Those exchanges are not protected in that way. And that's where we see more of, I'll call it, the disclosures outside that of bad actors that are hacking into systems and holding data hostage. But as far as the exchange goes, we don't see a lot of that today. Any other questions in the chat there, Sean? Or should we move on?
So far, yeah.
Okay, great. Yep, we'll keep going. So just a couple things. There are some other exchanges or other ways to do exchange. Direct is essentially a standard for, I'll call it, secure messaging. So more of a push where you want to send information. If you have their direct address, the direct address is essentially, again, like a secure email address for a provider. You can send them information. And some vendors, we talked about SureScripts earlier, some vendors have specific exchange standards for inside of their EHR, like some of the EHR vendors that I've mentioned below. So the next thing I'm going to talk about right now is the 21st century cure. So this is a federal regulation that's essentially putting some places, some agreements, some technology, and some language that can be applied to prevent organizations from blocking information from being exchanged. So the ONC coordinator, Mickey Trapathi, likes to call it the information sharing provision, but for now in the legal parlance, they call it information blocking. And essentially the requirement is for providers, health information exchanges, and networks and developers to allow and provide patients access to information electronically, leveraging the fast healthcare interoperability resources. So if for whatever reason in the legislation, they've identified information that needs to be made available directly to patients through the FHIR APIs, and you're not doing that, which is, as you can see the language in the bottom, then you're information blocking, and you could be fined or penalized for that blocking. Again, this is I gave it to you in bigger text in case the previous one was too small for you to read. But again, part of this is just giving people the information and giving patients the access to their information in a standard way where they can direct that exchange, they can direct that consent, and have access to the information that, again, historically, depending on where you land, whose information is it. The healthcare, in my particular opinion, the healthcare organization is the steward of the information, but the information belongs to the patient and they should have access to it. And this is putting that into legal language and under federal rules and requirements. So just to give you a sense of what we're talking about, the 21st Century Cures has a timeline. It has information about what data should be made available and when. In a second, I'll show you the timeline, but just to give you a sense of some of these things. Some of the data that's not specifically in the language today is some of the imaging pieces, which is a little more complex depending on the type of image that we're talking about. But again, it just gives you a general sense here of the types of information, the types of notes that are reshared. There are some exceptions. Sensitive note encounters, particular lab results don't need to be provided directly without the ability for the provider and the patient to connect and talk about those results. Again, some of those things may be things that are sensitive in nature or may cause patient harm. And so they've been written into the provision the ability for the provider to actually delay that release. But for the most part, most of that information is shared directly. We've even had patients that were in the hospital for a procedure get lab results on their phone prior to them being talked to by the provider or anybody in the hospital. Lab results were all normal. And so part of that process is just to release those results directly. Just to give you a sense of the timeline, so this 21st Century Cures has been in place for a while, and working through the information access provisions has been happening over time. Again, as we move forward in time, more and more information will be made available. By the end of this year, essentially, the provision of all EHI, which is all electronic health information. There's still some discussions around what that actually means and kind of how the organizations define the legal medical record and what can or is possible to be made available electronically via the FHIR APIs, and kind of how organizations will resolve that issue. But that is the final rule, and we'll start seeing some of those things, or we're in the process of implementing technology to support those things today. Now we'll talk about FHIR. So FHIR, again, Fast Healthcare Interoperability Resources, is a move of the healthcare technology vendors to a space that's more non-healthcare. Basically a lot of the interoperability standards have been, you've had to be very in-depth in healthcare and to facilitate that interoperability. This move to the FHIR API standards and the definitions and the requirements for organizations has really opened up the number of developers that can actually access health information, and has spurred some innovation in some of the more niche areas where you can get specific information about a particular condition. And I'll talk about a few of those in a minute. Just to kind of give you a sense of the FHIR adoption. So again, I've talked about some of these different standards before. The FHIR standard, and again, I say present day, this is probably a year ago, the proliferation of FHIR interoperability is continuing to grow. And I'll show you a chart just for our organization and the number of different FHIR connections that we have. One of the interesting things about FHIR interoperability is the ability to actually drop the transactions or the data into workflow real time where it's needed, as opposed to what I'll call the legacy interoperability, which again, I've labeled the redundant data strategy. So you take the same information and you send it all over the place, and you've got that information, and that's your car on the left. Is you've got access to all the information, you can get in the car and you can drive it, but it's not always the most efficient or prettiest way to do something. Whereas when you look at that VW on the left, it's an integrated car. You can see that it's all the same, it's all part of that, and essentially what the FHIR APIs do is it allows you to drop the data into workflow where the clinician needs it, when they need it, and in a way that it's not a redundant data feed, but you're actually accessing that information in real time and pulling it in where you need it. So, I think that what we're going to see is more and more FHIR interoperability. Doesn't mean the old standards go away or are ineffective, but it's a new way to do things to help smooth that transition for data sharing for new and unique use cases, and maybe eliminate some of the administrative burdens that the clinicians and the folks using the technology are encountering today. Just one quick example. If you have the little heart icon, if you have an Apple phone and the Android has a common health version of the same thing, but essentially this gives you the ability to log in or connect your medical record to your phone and actually download the information from, or at least from the EHR here at UC Davis and a lot of others. You can go into that little heart on your phone and actually pull in or look up your organization to see if they're actually connected. And essentially it'll pull in your medical record. So as you can see here, I did this a while ago and I used a test patient, but it pulled in 2,100 records, allergies, vitals, different conditions, immunization, lab results. And as you can see, when I drilled into it on the right-hand side of the screen, I can actually pull up a specific lab result that was in my medical record that I was able to pull into my phone. So again, this is giving patients access to the information. It leverages the APIs and delivers that data where you need it or want it for you as a patient.
And Jennifer Sosa had a question. I'm going to allow her to talk right now.
Sure.
Go ahead, Jennifer.
I'm so sorry. I actually didn't mean to test that button.
Okay, thank you.
I apologize.
It's okay.
No worries. All right. Well, if you figure it out and you do have a question, Jennifer, feel free to drop it in the Q&A or the chat. So just kind of our path or our vision to the FHIR APIs and looking at what we were doing. You know, part of what we wanted to do is make sure that you hear the term digital front door. Well, we wanted to enable the digital data front door to allow for all these different technologies to connect. So you got your Fitbit, your Apple. The particular use case I was talking about was Propeller in Northern California. We unfortunately have a lot of fires and not enough rain. And the Propeller application actually connects with APIs to allow for physicians to understand how patients are using their inhaler, how often, how large of a dose that they might get. And that information can be transmitted into the EHR. The physician might be able to make real-time adjustments to the patient's medication and give a better sense and understanding of when that patient is leveraging that inhaler and really try to tailor their care and the medications for that patient depending on those conditions. And again, there's different use cases that you can look at, Tide Pool, Gluco for glucose monitoring, other things that are out there. But for us, and part of the reason I include this slide is that we started looking at this and talking about this in 2019, knowing the regulation was coming and knowing the move to the FHIR standard, which hadn't been widely adopted, but had been created back in 19. We were moving in that direction. And really just looking at, you know, everybody's heard that term IoT or Internet of Things, you know, what's going to get connected, who's going to get connected. So our strategy is to connect, you know, all of our constituents. I love alliteration. So I got patients, partners, payers, providers, you know, we got public health. Probably should add that P in there since it fits in with the alliteration. You know, what was our current state? What things are we looking to connect? You know, obviously you got your car. So if you were coming to a visit, we've implemented wayfinding. So now we can essentially direct your car to the right garage. And when you get to the building, what door you come in and how do you get to your appointment, and working through wayfinding in the organization. I think we've all been to a hospital. It's difficult to navigate around. Where am I supposed to go? Where's the lab? Where's radiology? So, you know, integrating all these things so that you can get that information right to you where you need it, when you need it. And really that's our strategy, is to get that capability and that technology so that we can support all those different use cases around IoT. And this is just, again, in the last 12 months, the types of applications and use cases that have connected. Is there a question there, Sean?
Yeah, Steve had a question about HL7. I'm going to allow him to talk right now.
Sure.
Go ahead, Steve.
Hey, Mike, thanks for all this information. So the question I have is HL7 interoperability, and going back to what you said, it's being adopted. But we recently, and I'm just talking about, we're a health insurance. We had to implement the Medicare component of that due to a federal regulation. Now, the adoption of that to date, we have 0 people accessing that information. Now, granted, we're not responsible for coming up with the third-party apps that interface to us, but the adoption for it right now is 0. I'm just curious. You're telling me people are using the HL7 and the FHIR standard other ways. Maybe I'm just missing something.
Yeah. So what I'll flip back to you is, so if you look at on the left-hand side of the screen that I've got displayed right now, these are all applications that are coming in and connecting to our systems with the federal required HL7 standard that has been deployed. The one I'll point out to at the bottom, One Record, they're actually connecting payer by payer. So the first thing for your organization is there a directory where people can access your endpoint? And do your members understand how to actually access or connect to it? Do they have an online ID that they've been made aware of? Most of what I've heard on the payer side of this equation is that members don't normally log in electronically to your member portal as much as they might to the medical side where they're looking at their health records. Most of the access provisioning for that access is required to get access to the APIs and leverage that. And so depending on how your organization A, marketed it, and B, understood the population of members that are actually logging onto your electronic technology from just a member, if you have a member portal, and if you leverage that same authentication process for them to access that, and they're aware of it, and they know how to get to your endpoint. I mean, those are the sorts of things I'm hearing on the payer side, is that those APIs were deployed and they're out there, but organizations don't really know how to connect. What's the onboarding process? So again, the record has done a great job of going out in the community and connecting one by one payers to their platform, which is a PHR. And again, I would tell you that from that standpoint is, do your members understand how to do that? And do those third-party apps know where your endpoint is? Is there a directory out there or information somewhere that's not somewhere on your website to know how to connect? And those are the sorts of things, sorts of challenges that we're seeing, from our standpoint is we have a published endpoint and organizations know how to get there, and there's a directory for that. And I don't know if the same technology or mechanism is there on the payer side today, and that might be one of the limiting factors as to why your members aren't logging in or getting access to that information.
Well, we do have it published on the website. We do have a portal for it, and they have to create an ID to get access to it, which is all fine and dandy. But I think the adoption in terms of the demographics of how to use it, people that have Medicare aren't typically going to go out there and use their phone to download their medical records. I think that audience, by just simply knowing the age bracket, are not going to go out and do something like that. I don't know if that was designed on purpose by the federal government or
no,
what.
I think what they wanted to do was provide the technology and framework so that the providers for a long time have been required to do all this stuff. And I think what they were trying to do is level the playing field and give patients access to not only their clinical information, but their insurance information within the same framework. And I think, what you'll see is that the adoption of this sort of thing, once your members understand the value of having access to their claims information or whatever information you may have on file, clinical claims, or if you automate the if you can automate the auth process, if they need authorizations and then connect them to their payers, and then you can get access to their clinical information. I think that there's some use cases on the payer side that might add value for those Medicare members who are seeking access to care and might have some manual processes or paper processes that you can replace with some of that automation, especially when it comes to getting access to their provider information, which this technology can enable for you.
Right. I see the benefit. I'm not disputing that at all. I just don't see it being adopted yet. But the One Record, she's done a great job in that. And as far as the federal regulation, the pay-to-pay component was postponed. So kudos to One Record for doing that.
Yeah, for sure.
All right.
You're welcome. And thanks for jumping in. So just to jump back in the presentation, and again, Sean, just let me know if there's any other questions. This just gives you a list of the apps that are connecting to us. So the open.epic, and Epic is our EHR here at UC Davis. These are all the applications that have connected using FHIR APIs to get in and get information. And again, I don't go out on the web and try to research all of them. I worked with One Record for a while on some different committees, so I'm familiar with their organization. Common Health is the Android equivalent of the Apple Health. They just didn't go through, there's a vetting process that our EHR vendor has. They have an app orchard. So if you're part of the app orchard and want to connect via APIs, they have the ability to kind of onboard you onto that. So this gives you a sense of the list of ones that are onboarded through that process. And then essentially anything that's internally developed or that we're accessing for our own purposes internally, we're self-developed applications. So again, this is just over the last 12 months, and I would tell you that the number of applications that are connecting and will continue to connect are growing. And just for a payer example, we've actually connected directly with one of our payers, Centene, for a number of different use cases, including appointment scheduling for their members, integrating with their member portal, as well as the auth process through the DaVinci implementation guide. And the DaVinci is a work group that was spun out of HL7. They call it a FHIR accelerator. So again, FHIR. There's a lot of bad puns in healthcare interoperability around FHIR, but essentially gives you a sense of how to onboard and how to connect between a payer and a provider for those use cases like claims administration, member enrollment, again, referrals and authorization process. So how, as I provider, do I request an authorization? Is there another question out there, Sean?
Yeah, Gabriel asked, could be that security concerns is a limiting factor for the adoption of everything?
Well, the security concerns for people accessing their information and pulling it into another application could be a concern. And again, it depends on the population. So I know we were talking about the Medicare population. What I've found historically is that people who have a health condition are much more interested in getting access to their information and managing it themselves. And again, if you've heard, or I've heard a number of stories where somebody with a complex condition that have gone to a number of different providers and has to change health insurance organizations, has to carry a box full of documents as they go from place to place. The technology is supposed to enable that, and you'll find that the adoption is for people with chronic conditions or severe conditions that need access to information and do migrate between different organizations to get their care. That adoption is a lot higher than your normal, 30-year-old patient that barely goes to, their yearly check-in. So those are some of the things. I know that security is a concern, and the security concern from a patient standpoint is depending on the patient and what they want to have access to and where they want access to it, or whether they trust their healthcare organization to be the proctor of that information. So, and this is just a picture of kind of our enterprise strategy. So again, I love my piece. I should have put public health on here, but it just kind of gives you a sense of the technology, the data layers, the pieces that are in place, and how we're connecting them with different levels of technology, including those FHIR APIs. The last part that I'll talk about today is blockchain. So one of the things about blockchain is that a few years ago, blockchain was taking over the world. It was going to do everything. It was going to slice your bread. It was going to drive your car. It was going to, take over all the different pieces. And really what I wanted to just highlight here is blockchain is a technology. It's specific use cases like digital currency. Bitcoin runs on a blockchain platform. It's like a data storage mechanism for most applications. It's just a federated database or distributed database as opposed to a centralized database, which is what we know. And really what it's a particular framework that's really good for particular use cases. And in healthcare, there are a lot of different healthcare related projects or use cases. And again, this is a picture from a while ago of companies that are doing or enabling blockchain solutions or use cases where it's appropriate as opposed to replacing your EHR, which it's not going to do. Here's a list of some of those blockchain use cases. And again, as we move forward in the world, Web3 is a blockchain-based technology. So when you hear people talking about Web.3, the back end or the backbone of Web3 runs on blockchain. So it's not going away, and it's not just Bitcoin. And part of what we need to just is just understand the technology a little bit better, understand that it doesn't do everything. It's not going to, it's not going to replace existing technology, but it might augment. And I'll walk through a use case where if you blend, this is my magic blend, when you blend blockchain technology with some of the other frameworks that I've talked about, it actually gives you a better solution for patients to secure their data, to consent to exchange, and those sorts of things. Again, just some simple, how does it work? It's a distributed journal. The information is written into the log. That log is populated or essentially accepted by the network. So it's a network concept, and essentially nothing is written to the chain. You see the little check marks on the right until everybody actually accepts that, which is part of if you hear about Bitcoin and the mining, some of the processing power is that all that data is out there, it's written, and it's in essentially a ledger. So it's a running tab of all the information that's ever been written. Go ahead.
I was just going to say that we have to conclude this session here shortly. So if
okay, then we'll go fast. So some more information of blockchain as a concept, and really what we're looking at here for blockchain in healthcare is the first thing that if I need to exchange information is blockchain for identification. So if I know who you are and I traverse the healthcare organization or infrastructure, I can actually understand, kind of the who you are and where you've had care. I can leverage those existing frameworks across the network to do that exchange. And if I essentially move that forward and say, not only am I going to have an identity, but I'm also going to any encounter that I have. So my encounter chain, any encounter that I have with those organizations, I'm going to put that on chain. And essentially what I've created is a linkage between a person and each of their encounters. So as organizations participate in a blockchain or an activity with the patient, a prescription refill, an EMS transport, what have you, as you can see here, I've got my identity chain and my encounter chain, and I can actually say and take that and aggregate that to your view on your right, where you got a longitudinal health record. And again, part of the beauty of blockchain is not only that it can facilitate that identity, can facilitate the track and trace process of the encounter chain, but it also can manage consent. So if I don't want to have, let's just say doctor or prescription 1 and doctor 2 was a mental health visit that I paid cash for, and I don't want to exchange that with other people, I have the ability through the consent mechanism that's enabled by blockchain and that security to eliminate that from that exchange, or from sharing it with people that I don't want to share it with. And at that, again, I went fast through the blockchain piece, but we were ending there. So I'm going to go ahead and take any other questions that I might be able to help answer today. And I appreciate the forum.
Thank you, Michael. Steve asks, what would be your recommendation on learning HL7 or FHIR?
So HL7 is the organization. So I would tell you to get on hl7.org. They have a significant number of training resources, webinars, actually for my team here. So I've got a development team that's moving from legacy interoperability to the FHIR-based interoperability, which is very different than what we've done historically. They've attended HL7 online training for FHIR. So there's an intro, there's an advanced, and really kind of there's a developer course. So if you wanted to build an app using FHIR connectivity, how that would work as well. So I would tell you that they're a resource. HIMSS is also the Healthcare Information Management Systems and Society. They have a lot of content around kind of the legislative pieces and kind of how to tie those things together. So if you want training on how to do FHIR or what it is, hl7.org is the website. If you want to kind of talk about implementation or what some of the other meaningful pieces are, you might want to check out the HIMSS website as well.
Well, that's a wrap. And I hate to cut it off because I feel like we had some really great questions and some content. So Michael, thank you so much for your time.
Yeah, thank you.